Welcome to this explainer, where today we're going to unlock what I honestly consider a true clinical superpower. We're going to learn exactly how to pinpoint silent brain lesions, tumors, or even strokes simply by mapping out a patient's sight. Look, if you've ever stared at a visual fields plot and felt completely overwhelmed by all that data, get ready to change your perspective. By the end of our time together, you're going to be able to look at any visual field defect and immediately trace it back to its exact anatomical location in the visual pathway. Okay, let's dive right in. To really understand visual fields, we've got to start with this brilliant topological concept defined by Triquer way back in 1938. He described normal human vision as a hill of vision surrounded by a sea of blindness. Think of the very peak of this hill as your fovea, the center of your gaze, where light sensitivity is at its absolute highest. Then, as you move outward into the periphery, that sensitivity gradually drops off, eventually plunging into the surrounding sea of blindness, which is just limited by your facial anatomy, your forehead, nose, and cheekbones. So when we test visual fields, we are essentially just mapping the exact topography of this specific hill for our patient. So here is our diagnostic blueprint for today. We'll be covering the map of sight, pre-chiasmal clues, cracking chiasmal lesions, post-chiasmal detective work, and finally, a final diagnostic checklist. Section 1. The map of sight. Let's establish the geographical map of human vision. Think of the complete anatomical visual pathway like the wiring of a really complex security system. It starts at the very front with the retina, travels down the optic nerve, meets at this ultimate neurological crossroad called the optic chiasm, and then travels deep into the brain. It goes through the optic tract, the lateral geniculate nucleus, the optic radiations, and goes all the way back to the striate cortex in the occipital lobe. The key thing to remember is that every single visual field defect corresponds precisely to a break somewhere along this specific wiring. To act as a clinical detective here, you've got to mentally slice this pathway into 3 distinct geographical zones. Step 1 is pre-chiasmal. That's anything before the crossing, meaning the retina and the optic nerve. Step 2 is chiasmal, right at the intersection itself. And step 3 is post-chiasmal, which is literally everything from the optic tracts all the way back to the cortex. If you can just categorize a defect into one of these 3 zones, honestly, you've already done 80% of the diagnostic work. Now, before we actually start hunting down a lesion, we have to classify what we're looking at. We need to figure out if the vision loss is a diffuse loss, which is basically a generalized sinking of that entire hill of vision we talked about, or if it's a focal visual field loss, which we call a scotoma. A scotoma is an isolated specific pothole in that hill. It's these highly specific focal scotomas that are going to give us the exact geographical coordinates we need to hunt down a lesion. Section 2, pre-chiasmatal clues. The detective work begins right at the front of the pathway. All right, the absolute golden rule of pre-chiasmal damage, it causes strictly unilateral defects. Because the signals haven't crossed yet, a lesion in the right retina or the right optic nerve is exclusively going to affect the right eye. And within this zone, we can narrow things down even further. Retinal vascular issues, like a blocked artery, typically respect the horizontal midline. Optic nerve head issues, like glaucoma, well, they might show up as an arcuate scotoma or a nasal step. And what's really fascinating is that lesions specifically inside the optic nerve often damage the papillomacular bundle, which just hits central vision incredibly hard. So let's put this into practice. If a patient presents with severe focal loss in just one eye, that instantly tells us we're in pre-chiasmal territory. The underlying culprit might actually be an indolent compression, like an optic nerve sheath meningioma. These are slow-growing tumors that arise from the arachnoid cells of the meninges, and they typically present with a drop in visual acuity and optic disc swelling, leading to optic atrophy. In cases like this, the visual field defect is often the very first major clue that something is physically squeezing that individual nerve. Section 3. Cracking chiasmatic lesions. Let's trace those wires deeper into the brain to the optic chiasm. Here is a classic clinical mystery for you. Imagine a patient sits in your chair, and their test reveals they're missing the outer temporal half of their vision in both eyes. We call this a bitemporal hemianopia. They're basically walking around wearing neurological blinkers. So where exactly is the culprit hiding? To crack this, we absolutely have to compare both eyes. We classify binocular defects as either homonymous or heteronymous. Homonymous means the exact same half of the visual field is missing in both eyes, like the right half of the right eye and the right half of the left eye. But a bitemporal hemianopia? That's heteronymous. It affects opposite halves, the right half of the right eye and the left half of the left eye. This heteronomous pattern is the absolute, undisputed hallmark of a chiasmal lesion. The anatomical why behind this is just fascinating. Right at the optic chiasm, only the nasal retinal fibers cross over, or decussate to the other side of the brain. And these nasal fibers are responsible for your temporal visual field. The temporal retinal fibers, they stay on the exact same side. Now, the most common cause of a chiasmal lesion is a pituitary adenoma. Because the pituitary gland sits directly below the chiasm, a tumor growing upward compresses those crossing nasal fibers from below. This initially wipes out the superior temporal visual field, which creates that highly specific heteronymous defect we just talked about. But hey, tumors are not the only threat hiding in this area. Unruptured aneurysms in the circle of Willis can also act as really dangerous compressive masses. The optic chiasm is surrounded by major arteries, like the internal carotid and anterior communicating arteries. If an aneurysm balloons out right here, it can press directly against the chiasm, causing visual field defects way before it ever bursts. Catching this specific visual field defect early could literally save a patient from a fatal subarachnoid hemorrhage. It's that serious. Section 4, Post-Chiasmal Detective Work. We are moving even deeper into the pathway now. Here is your unbreakable clinical rule for this zone. Post-chiasmal lesions always, and I mean always, produce homonymous defects. Because the fibers have already crossed to the chiasm, the right optic tract now carries all the information for the left visual field from both eyes. Therefore, a single lesion anywhere in the right post-chiasmal pathway is going to blind the left visual field of the right eye and the left visual field of the left eye. But how do we know exactly how far back that lesion actually sits? Is it in the optic tract, the radiations, or all the way back in the cortex? Well, the secret key here is congruence, which just means how identical the defect's shape is between the two eyes. It's a pretty simple scale, really. The further back into the brain the damage occurs, the more perfectly identical or congruent the visual field loss is. Optic tract lesions, highly incongruent. By the time you reach the lateral geniculate nucleus, they're relatively congruent. And if the defect is completely identical in both eyes, you are definitely looking at a lesion all the way back in the striate cortex. Another incredible clinical pearl to watch out for deep in the brain is macular sparing. Sometimes a patient will present with a complete homonymous hemianopia, literally missing exactly half of their vision, but their central macular vision is miraculously spared. Why does this happen? Well, the macular fibers have a massive redundant representation area at the very back of the striate cortex, often with a dual blood supply. So if you see complete congruence with macular sparing, you're almost certainly dealing with a lesion in the occipital lobe. Now, we've talked about tumors and aneurysms, but it is absolutely crucial to remember that once you hit the post-chiasmal radiations and cortex, vascular damage is king. Specifically, a stroke is by far the most common cause of these homonymous defects. The visual pathways back here fan out massively, and the really thin networking vessels supplying them are incredibly vulnerable to ischemia. Section 5, Final Diagnostic Checklist. Let's pull all these distinct clues together into one actionable plan. This is your rapid-fire diagnostic blueprint to use in the clinic. Commit these golden rules to memory right now. If the defect is strictly unilateral, the lesion is prechiasmal, so focus on the eye and the optic nerve. If it's a bitemporal heteronomous defect, the lesion is at the optic chiasm. Start thinking about a pituitary tumor. If it's a homonymous defect, you're looking post-chiasmal. And always remember the rule of congruence. The more identical the defect between the two eyes, the further back in the brain the lesion sits, ending in the striate cortex, which, as we just learned, often features macular sparing. So, by mastering this clinical logic, you're elevating a routine eye test into a profound neurological map. You aren't just looking at missed flashing lights anymore, you're actually tracing the physical wiring of human sight. The next time you sit down with a visual field plot, use these rules to hunt down that lesion. Because identifying these silent defects early doesn't just save a patient's vision, it can literally save their life. Keep this blueprint handy, keep asking questions, and never stop investigating the incredible map of human sight.